Yeah, so Clarkson's disease is a rare monoclonal gammopathy of clinical significance. Patients present with recurrent shock, hypotensive, but there's no obvious trigger. They're not infected, they're not allergic to anything. These patients, by definition, all have a paraprotein, so a monoclonal protein in their blood that's identified by S-pepin immunofixation. This is an incredibly rare disease. Basically, treatments elucidated from case reports in very small case series, but what we've learned is that treatment of using drugs that treat myeloma, all the stuff that works for myeloma will work for this disease to get rid of that clone secreting the monoclonal protein. Typically, we start with IVIG every month, but if that doesn't work, you can use immunomodulator agents like Revlimid or Velcade and other proteasome inhibitors. For multiply relapsed DLBCL, we have many options, including CAR T cells and bispecifics. I'm typically favoring CAR T cells as they have more of a proven track record. We have longer follow-up, and we do think we're curing roughly 30 to 40% of those patients. So if a patient is a candidate for CAR T, which is a whole lengthy process to determine, we are electing CAR T. Now, some patients, they're not a candidate, or they don't want to go through the risks associated with CAR T cells, or as a treating physician, I think the CAR T cell is too risky for them. Too old, they have other major medical comorbidities. Then I'm electing bispecifics. Bispecifics have a good track record, but not as long-term follow-up as CAR T cells. And I can't promise my patients that we're curing any of them, but they can experience long-term durable remissions. They do require continuous infusions. So if the patient lives far away from the cancer center, that can be a hurdle to cross. Although more community centers are now starting to use bispecifics, we typically would do the first week or two at the university, and then when things get easier, the bispecifics can be administered in the community. With relapsed myeloma, again, a bounty of choices. Typically, we are favoring CAR T cells like cilta-cel if they are a candidate. We're not curing anyone, unfortunately, in myeloma with CAR T cells, unlike in relapsed lymphomas, but these are patients who have limited options or have been getting continuous therapy forever. With CAR T cell, they can get treated, recover, and experience remissions on the order of years. So I'm typically favoring cilta-cel for those patients, again, if they're a candidate and understand the risks and are willing to accept those. If cilta-cel is given and then there is relapse after cilta-cel, or I will then go to the bispecifics, I typically would use talquetamab after using cilta-cel because it targets a different protein than cilta-cel. And I would use talquetamab for as long as it's going to work, and then when that stops working, go back to the other bispecifics like elranatamab, which targets BCMA. For patients who are not eligible for CAR T cells or don't want to do them, then we're using the bispecifics first. For low-risk MDS, right, we used to have really no good therapies other than transfusion support. We always had lenalidomide for 5q-, which isn't very common, and then erythropoietin stimulating, so like Aranesp, darbepoetin. So there now are two drugs, luspatercept and imetelstat, which are approved in low-risk MDS, and the goal of both those therapies is to improve the anemia. So luspatercept is an infusion, and it used to be just approved for those with ring sideroblasts or SF3B1, but that drug is now approved for all low-risk MDS. You don't need to just have that specific mutation, although it does seem to work better if you have that mutation, but it doesn't mean it wouldn't work in the other low-risk myelodysplastic syndromes. It doesn't cause infections. There's serious side effects. There's some infusion-related reactions, but most people tolerate it well. And in about half of patients, maybe a little bit more, it can raise the hemoglobin a few points, thus mitigating their need for transfusions. Imetelstat does a similar thing. I'm typically using that after erythropoietin stimulating agonist and luspatercept stop working, and then we can use that drug. It has just slightly other side effects, including low platelets. It can irritate the liver. It's a little bit more involved. But again, it gives another option to our patients as opposed to just getting continuous transfusion support. Sounds cliche, but our patients, they're really with blood cancers. I mean, I went through on my first few slides all the FDA approvals. There's multiple new approvals, I feel like almost every month. And this is very good news for our patients. I still think we need to be very transparent with our patients about the success of some of these drugs and the side effects. These all come with significant financial toxicity, time toxicity, and side effects that can greatly impair the quality of life for our patients. So again, it's good to have a lot of options, but it can make it very difficult to have these discussions. So it's good to be informed if you're a patient, and it's good to inform your patients of all the options.